Thank you everybody for joining us and welcome to meeting number 18 of the Biomedical Scientist Empowerment Education and Discussion Group. So without further ado, we're going to move on to today's session. Every minute counts, supporting the safe release of blood components in an emergency. And you may recall in January this year, the MHRA released a CAS alert from their central alert system around preventing transfusion delays in bleeding and critically anemia patients. And we know that the urgent provision of blood components and products is vital for life-threatening bleeding and severe anemia. However, reports of such continue to come into shock with numbers increasing year on year, and Shruthi and Jenny, our speakers today, will be speaking about that. So I'd like to welcome Dr Shruthi Narayan, Medical Director of SHOT and a consultant in donor medicine at NHSBT, and Dr Jenny Davies, the Transfusion Laboratory Manager at the Royal Devon University Healthcare NHS Foundation Trust. And they're going to be speaking to us today about supporting the safe release of blood components in an emergency. So I will now hand over to our speakers. Thank you very much.
Thanks very much, Danny and Selma, for inviting us to actually be part of this in these string of sessions as well, and really welcome this opportunity. Let me share my screen and then we can begin talking. And we have a contingency plan in case this does not work, so don't worry. So, is everybody able to see my screen?
Yes, looking good.
Okay, that's great. So as Danny mentioned, today's session is largely focusing on how do we actually support safe release of blood components and avoid delays in an emergency. I would really like to actually thank every one of you, and especially with all the challenges that we have faced during the pandemic, which is still actually not gone, and contributions to transfusion safety. So all of you, do an enormous, work and keep up all the great work that you're actually doing. And in this session, I think first I would like to just spend an initial couple of minutes explaining the context. What has been the learning from the SHOT reports, but actually the wealth of the discussions would be actually in our case-based discussions that we'd be doing. And this is meant to be interactive, so please do pose all our questions. Obviously, when I'm sharing the screen, I can't see the chat function, but others would be having a look. Now, I see many people were asking about the VWalks. Yes, this is optional. Now, if you are using any of your smartphone, you can actually scan this QR code. All this really does is in an anonymized way, you would then be able to interact and actually get involved in all the discussions that we're having in this webinar. So you can, if you have by chance downloaded, you don't need to download anything, but if you're already on a login page, if you just Google VWalks login, it would be asking, and then you can put these numbers. Don't worry if you don't have these numbers in every one of the slides, this number would be appearing. Or if you can scan this QR code, it would then take you directly to this. I'll give you 10 seconds or so to do that. And so the first question, we have a couple of warm-up questions as well. So if I then say, how are you feeling at the start of this session? And I will start polling. So as you can see at the bottom, top left, I'm getting all my orientation wrong. So here you can see it tells me 50 people are on the VWalks and they're beginning to submit the responses, and I can see. So I'll give you a few more seconds because this is more a warm-up, and it is then telling me, yes, people are actually then putting in the answers. And I can close the poll when the number is actually over 50 or nearing 50, so that we get a hang of things. And thanks everybody for actually participating. So this is actually just a great way to actually build in interaction into the presentations, and especially in a virtual setting. Okay, so we've got around 50. So let's see what people are actually saying. Now you should have magically a word cloud that would be actually coming up on the screen that would then tell us. Okay, so we see predominantly people are feeling good. They are overwhelmed. Completely get that. I think, we are trying to do more and more with less and less people. Interested, great, thanks, very good, lovely. So thanks very much for actually then, letting us know how you feel. Now getting along with more questions. This is about hemovigilance. So hemo is blood and vigilance is surveillance. And essentially what we are really trying to do is from the data that is actually submitted and the intelligence, can we actually then understand what hemovigilance is? Now this is a I'm getting some echo. if everybody else can go on mute. And this is a multiple choice question. So there is more than one right answer here. And we are saying which of these is the correct, which of these are the correct statements. So whether hemovigilance is optional and we only need to engage if we have adequate resources, or hemovigilance is a must to improve transfusion safety. Hemovigilance can be effective only with bidirectional traceability. And what does hemovigilance help? Does that result in quality improvement, or reporting alone does not suffice? So which of these statements do you agree? And if people have logged on late, yeah, this is VBox. If you just search, Google search VBox, join, and then it'll ask for an ID. At the top end right side, you can see 106907009. Okay, so I've got quite a lot of responses. So let us close this. And then if we see, okay, oh, I see 3% going for an answer. It is optional. I would tend to disagree. Hemovigilance, patient blood management, two sides of the same coin, because unless we actually know how safe transfusions are and hemovigilance is the source of that information, you really would not know where to focus your efforts as well. So to me, and to everybody, it is a must to improve transfusion safety. And you're right, it is only effective when we have bidirectional traceability. So it's really, really important. And it is not just data collection. What are we doing with the intelligence that we get? Is it actually improving the transfusion safety, not just for patients, but also for donors as well as for staff as well? So you've got the right. So as you can see, even in our case-based discussions, it would actually go through the same format. We would be asking, you would be giving your choices, and then it would also indicate which one of these is the right answer there. So I hope everybody is warming up to this. Now, this is the graphic that we actually produced, I think, end of last year, to actually just capture that hemovigilance, although majority of the short report that you would see are more at the patient end, it is really important to note that this hemovigilance applies to the whole journey of blood. So right when we actually then collect the donor, so there is donor hemovigilance that would be actually dealing with, everything related errors, adverse events related to donors. Plus there is the hemovigilance in a blood establishment as well, with all the processing and the manufacturing, and at the patient end. So hemovigilance covers vein to vein. And for those who are not really familiar with SHOT, now incidentally this year we are celebrating the Silver Jubilee for SHOT, and we collect and analyze the information related to transfusion reactions. This is not comprehensive, it is on the limited categories and also on error reports, but also importantly we collect on the near misses, and near misses account for nearly 1/3 of the reports that we receive in SHOT. And there are two parts that we need to remember when we talk about transfusion safety. We are talking about the safety of the blood itself, the blood components, but also important is the process-based safety. So, and we know that the transfusions are actually complex. It goes through the whole, journey of the blood. And we are also actually then having at the patient end, making the decision to actually transfusing as well. So therefore, there are many errors that can be introduced in the process. So you're really looking at both blood safety and process-based safety. So another of the warm-up questions. So have you downloaded the SHOT UK app? Okay, so I see the responses are coming in much more quicker. So I think, people are becoming more familiar with the VBox. So let me close this. Okay, so we have 42% who have actually downloaded. So thanks very much. So the only reason we are actually promoting this is all the resources that you're actually finding, the different videos, the short bites, everything can be accessed on the SHOT app. So please go to the App Store. So whether it is actually Apple or the Android, and if you search for SHOT UK, you should be able to actually download this freely, and you will get notification of all the events. Now, why are we in this, in this session, and what are we actually talking, and why are we talking about this topic? So as you may be aware, the delayed transfusions are one category where we collect the reports, and year on year, and this is actually giving you for the whole of the last decade, you can actually see that the reports are increasing year on year. And last year was actually the highest number that had been reported. So we had 133 instances of delayed transfusion. This is both due to, combination of clinical, laboratory, and multiple factors. And there was also the number of deaths, as you can see in the red bar, the number of deaths that are being reported are also actually increasing year on year. Now, the question is, okay, what are the top 2 causes of transfusion-related deaths in the UK? I may have given up one of the answers already. So you have 2 choices that you can actually choose here. What are the top 2 causes of transfusion-related deaths? And so you have to take 2 choices and enter Okay. So let me close the poll and let's see the answers. Okay. Now, there is a wide range of the answers, but I see majority have actually gone in for the delayed transfusions and the TACO, that is the transfusion-associated circulatory overload, which are the right answers. Now, any of those categories can result in the death of a patient. Yes, we have had patients dying with hyperhemolysis. We have had patients dying as a result of the ABO incompatible transfusions, as well as due to TTIs, that is the transfusion-transmitted infections. But by far, from a numbers point of view, we see that the number of the deaths that are happening due to TACO as well as the delayed transfusions are among the highest. And this gives you, this is a busy graph, but you can actually see in all of these focus on the orange as well as the red parts of the bars. So you can see that, the TACO that is in the orange bar and then the red is the delays. These two are the most common causes of the transfusion-related deaths. Now, what prompted us to actually release the CAS alert was that jump. As you can see from the numbers in 2019 to 2020, the number of the deaths reported also increased, and that increase was actually largely not just the increase in the TACO cases, but also the due to the delays. And you have seen this CAS alert that that is to address all the preventable delays, and this covers not just major hemorrhage scenario, but also the emergency provision of the blood, say in a patient with severe anemia, also with severe hemolysis as well. And another important aspect is actually the delays in the provision of the prothrombin complex concentrate as well. Now, we know definitely these are underreported to SHOT, and but there are certain themes that are coming in. So, PCCs, which are, valuable in reversing anticoagulants, especially warfarin. Now, as soon as you so if you have a life-threatening or a limb-threatening bleed, once you've made that decision to actually treat, it should be started within an hour. But often what we actually see, there are different complexities, people not becoming familiar, they don't know where it is given, they don't know how it is given, and it results in delays, and that can actually result in the death of the patient as well as debilitating effects. So it's really important to actually ensure that there is a timely provision of PCC, and that is why every minute counts in all of these emergency situations. And when we look at the factors that contribute to the delays, to the left side, you can actually see the spider diagram, which is actually telling, there are multiple factors when we look at it. So whether it is actually, from somebody recognizing that there is a life-threatening bleed going on, to, communication issues, to IT issues, to errors in interpreting the results as well. And when you look at all the themes, it is largely, to the right side, when you look at the bar chart, you can see all reports noting communicating issues. There are 71 cases where you had communication that played a role. So by far, it is communication between teams, between the personnel within the team. So we really need to look at improving the communication. And so these were the key recommendations to address the transfusion delays. I'm not going to go through all of them in detail. These both pertain to the clinical as well as the laboratory. But the main thing that we are actually saying is have your major hemorrhage drills, are they simulations? Because it is all about muscle memory. We learn to actually work together in teams if we have actually been practicing it, doing it again and again, identifying a leader, identifying that communicator, identifying somebody to keep a track of everything that has actually gone on, and you're making sure that you're actually then learning from all of these. And laboratories should ensure they have a robust procedure for the concessionary release. You don't want a patient dying from want of blood. And that is what we shall be actually discussing today. Also, we need to remember that in all of these emergencies, your communication channels, you should not have a phone that is engaged, you don't have any other means, or the battery is actually gone and you can't get in touch. So you need to really have reliable communication channels that function well to ensure that there is a correct pathway for activation. Plus, you should have a common language. So when that activation is actually taking place, all the necessary details are actually being, given. Laboratory staff should be actually able to, understand and get that urgency of the transfusion and what is actually required. And we also need to actually audit and learn from experience as well. So now for all the more exciting bits about the case-based discussions, and I'll hand you over to Jenny, and we will keep also, going through the different scenarios and the learning from each of them. So Jenny, over to you.
Lovely. Thank you very much, Shruthi. So yes, we're going to go through now some interactive case studies, and these cases are based on real events. So they could happen to you when you're on duty, may well have already happened to you while you're on duty. And as we go through them, I want you to imagine that you're working on your own out of hours, so you don't have any colleagues with you that you can ask easily, and so you have to make a decision about each case. So we'll go through the case that you can see the first one on the screen here, and then we'll use VBox. You'll have some options about blood provision to choose from. And so you can select the option that best fits with what you think you would do in each of the scenarios. And we do want this to be interactive, so please do use the chat, put your hand up, etc. if you want to. So case 1, we have got a patient with an autoimmune hemolytic anemia. So a 56-year-old female, she's come into the medical ward. We've had samples down for full blood count and group and save, and they're showing autoimmune hemolytic anemia. Hemoglobin is low at 46 grams per litre. The patient's known to haematology and has a transfusion history. And we've processed our group and save, and it's showing group A D positive, which is consistent with her historic results. And we've done an antibody screen and identification panel that is positive with all cells due to the warm autoantibody. But the patient's symptomatic and the consultant haematologist wants to transfuse 2 units of red cells urgently. So what are you going to do? So using VBox here, so are we going to tell the clinical teams to take the emergency group O blood because we can't provide any compatible units? Are we going to send the sample to the blood service for an urgent cross-match and tell the clinical team that they'll have to wait because we can't provide any compatible units? We have to get them from the blood service, which may take several hours. Are we going to release ABOD compatible red cells using a rapid release protocol or best match protocol? Or are we going to release ABOD compatible RH and K matched red cells using our rapid release or best match protocol? So you can make your selection. I can see some people are putting some in the chat as well, I think, so that's great. Yep, quite a lot coming through the chat.
I'll close the polling now, Jenny.
Okay, thank you. And there's lots of 4s coming through the chat. Okay, so some people would let the emergency group O blood go out, and quite a few would say to the clinical team to wait for blood coming from the blood service. But majority of people have gone for number 4, yes, absolutely, which is to provide ABOD compatible RH and K matched using our rapid release or our best match protocol. So why do we go down that route? Well, we really want to conserve our emergency group O units in the fridge so that they are there when somebody who actually needs them can have them. So when we've got a sample in the lab that we can provide blood from, we don't really want those emergency group O bloods going out of the door. And especially with O negative, because we really need to conserve that for people who need it. But we do need to provide blood rapidly for this patient. Autoimmune hemolytic patients, anemia patients with a low hemoglobin. And sometimes the cutoff for that is about 60 grams per litre or less. They are at risk of heart failure. Their hemoglobin fall can be unpredictable and can be very rapid, and patients have died from delays in provision of blood, and SHOT have had reports through of that as well. So we do know that these patients, they're difficult to cross-match because the autoantibody can mask underlying alloantibodies. And we do know that if they have a transfusion history and warm autoantibodies, there's quite a high chance of an alloantibody being underlying. There's about a 20 to 40% chance. But we also know that about 75% of alloantibodies are to RH and K antigens. So if we're matching for those as well, we're covering a lot of bases there in terms of safety. And we can do RH and K testing because that's not affected by the presence of autoantibodies. So it is safe to release ABOD matched, RH and K matched under concessionary released with the consultant hematologist or hematologist. And then the hematologist knows what's going on and they can monitor the patient appropriately. And yes, we probably do want to send a sample to the blood service as well for testing because there may be an ongoing blood requirement for this patient. Okay, I can see some things coming up in the chat as well. I don't know whether we want to talk about those now or somebody's saying you may not be able to, I think, sorry, I can't see the chat very well from my laptop, but I think somebody says quite rightly that you might not be able to do an RH and K type if the patient's been recently transfused. That's absolutely right. So you really should have that on the baseline for these patients. But ABOD then, if you can't do it, is a safe option.
Yeah.
Right.
Sorry, Jenny, I can't see anything, any chat box because I'm sharing the screen.
You want me to read them out for you?
There's quite a lot. I'm trying to pick them up as they pop up at the top of my screen, and I saw that one. Are there any others that we want to discuss? Or shall we move on to case 2? Move on to case 2.
I think let's move on, yeah.
Okay, lovely, thank you. So this SUNX case, we've got gastrointestinal bleed in a patient with red cell alloantibodies. So 45-year-old male, he's come into ED with GI bleed. They haven't called the major hemorrhage protocol, but they do want 4 units of red cells urgently for this patient. His hemoglobin's 75 grams per litre and the bleeding is ongoing. So the patient has a transfusion history and is known to have anti-little c plus JKA. And you have tested a sample and the results are consistent with historic antibodies. You've got some ABOD compatible little c negative red cells in stock, but they're not JKA typed. So what do you do? Are you going to tell the clinical team to take the emergency group O red cells because you can't provide completely compatible units? Are you going to order some little C neg, JKA neg red cells from the blood service on an emergency delivery and tell the clinical team they have to wait until the compatible units arrive? Or are you going to order some little c negative, JKA negative red cells from the blood service on an emergency delivery, but in the interim, release ABOD compatible little c neg red cells that you've got using the rapid release protocol or best matched protocol whilst waiting for delivery of your blood from the blood service? So I can see in the chat, I can see people are mainly going for number 3. So we'll see. So yes, a few people are going to tell the clinical team to wait, but majority of people are going to go with the best match that they've got whilst they're waiting for some more blood to arrive. So that's great. Okay. So why do we go with that then? Again, conserving our O-neg and O-pos stock, emergency stock in the fridges, but also the hemoglobin is quite an unreliable parameter in bleeding patients. The situation's dynamic and the patient can deteriorate quite quickly in these cases. And we've used quite a low hemoglobin for our case, but you may be asked as well to cross-match blood when the hemoglobin is higher than this. Which may seem a bit odd, but it's difficult for the clinical teams sometimes to estimate blood loss, particularly in a GI bleed where it might not be very obvious to them. So it's best for us to get those units cross-matched and out there as quickly as we can so that they're ready if they're needed. And if it turns out the situation changes, it turns out they're not needed, then we can always bring them back into stock. And yeah, in this scenario, we're going to go with our ABOD compatible C negative units. You can JK type the units yourself, and I think I saw somebody put that in the chat, so you can absolutely do that. That's a good thing to do. And again, get out your concessionary release form so that the haematologist and the clinical team are aware of what you're doing. There is some risk of a hemolytic transfusion reaction here, but clearly the patient's having a significant bleed. And so the benefit outweighs the risk here, and the clinical teams are all very well aware of what's going on. And keeping in touch with the clinical team and good communication is really important here, because you can plan ahead, and particularly if you need to order in more red cells from the blood service as the situation is ongoing.
Thanks, Jenny. I completely agree, because especially with that ongoing communication, because I think from a clinician, you really want to know when to expect and what is to be expected as well. So I think that is really, really important in such emergency situations.
Yeah, it's important for the lab as well, isn't it? Of course, because you need to know how many units do I need to order down, etc. So communication is always key in all of these critical and emergency cases. So case number 3, we're going to talk about, so option 3 is the correct answer, yes, in the chat there. This next case, so we have a 74-year-old male who's admitted following a road traffic accident. He's got severe injuries because of this accident, and the clinical team need to take him directly to theatre, and they want 4 units of red cells urgently. So you've had 2 group and save samples for this person, and you've processed them through the analyzer. But the analyzer hasn't been able to give you an ABO group interpretation. All the results are positive for both the forward and the reverse groups. The D group is fine. Yes, everything's positive. You're not able to do an ABO interpretation. You don't know what to do. You have got a D group though, and he's D positive. So you try doing a manual ABO group, but you still can't work out what group this patient is. So what are you going to do in this scenario to get those 4 units out? So are you going to tell your clinical team that they'll have to take the emergency group O red cells because you can't provide anything at the moment without a blood group? Are you going to send the sample urgently off to the blood service and ask them to provide compatible red cells because you can't do it? Tell the clinical team they need to wait for blood to arrive, which may take several hours. Are you going to send your sample urgently to the blood service for confirmation of ABO group, but in the interim release group O red cells, which are decompatible with the analyzer result? So I can see quite a few 3s coming in through the chat. And we're closing the poll, so we'll see. Yep. So here, again, some people have gone for letting those emergency group O's out of the door. A few people, 1.37% of people are telling the clinical team to hold off theatre while they get it sorted out. But majority of people have gone for that option number 3, which is to release group O red cells, which are decompatible with the analyzer result in the interim, which is correct. And conserving our group O's is okay. So we're taking the safe option here, group O red cells. But the important thing here is to be mindful of the need for plasma components as well, and to think about what your LIMS allows you to do. Can you issue group O red cells without a blood group in your LIMS? And if you can't, and you have to call the patient group O, think about what impact that's going to have on your plasma components, your FFP and your platelets, because ideally we would want to be going down the safe option of A or AB plasma components in that. And also be clear about communication here. If you're having to tell your colleagues on the next shift that you're having to give them group O blood, then be careful that you're saying group O red cells and being clear about the group for the plasma components as well, because that's really important and could result in error.
Thanks, Jenny. And I think I agree, because when we look at the number of ABO incompatible transfusions that are being reported, increasingly over the last few years, it is actually relating to the plasma components, so that element of confusion. And we've also seen incidents where there is a note on the laboratory about, giving the components for the red cells, which has been misinterpreted for universally for even including the plasma components. So I think it is, needing to know when you're talking about universal components, it's different for the red cells and the plasma components.
Thank you. Right, case number 4 of no irradiated red cells. So this time we've got a 24-year-old female. She's got known Hodgkin's lymphoma, and she's come in with severe bleeding from a stab wound. The hemoglobin's been done 20 minutes ago, and that was 78, so it's quite low. The patient's going to theatre immediately, and the clinical team want 4 units of red cells urgently. The patient's got a history of transfusion on the limbs, and your current group and saves shows ABOD type consistent with the historic, and antibody screens negative, but the limbs is flagging up a need for irradiated red cells. And you've only got 1 unit of irradiated red cell in stock that's ABOD and K compatible for the patient. So what are you going to do this time? Are we going to tell the clinical team to take the emergency O-neg, as you don't have sufficient compatible irradiated red cells, and place an urgent order with the blood service? Are you going to place an urgent order with the blood service for ABOD and K compatible irradiated red cells and tell the clinical team they have to wait until the delivery arrives? Or are you going to place an urgent order with the blood service for ABOD and compatible irradiated red cells, and in the interim release the 1 irradiated compatible red cell that is in stock, along with 3 ABOD and K compatible non-irradiated red cells? Okay, so there's quite a lot of option 3s coming through on the chat again, I can see. And somebody's saying they'd want to inform a haematology medic. So yeah, absolutely, nearly everybody's gone for option number 3, which is the correct one. Absolutely.
Jenny, one thing I did realize is in all our answers that we have actually chosen the order, or we should juggle that up from a human factors point of view. I didn't realize moving through questions.
It's all right. It's not always the last one.
Yes.
But it's not supposed to be trick questions, so I'm quite happy with that. So yeah, again, the rationale for this is that we want to conserve our emergency blood. We've already said that the hemoglobin in bleeding patient is unreliable, so we can't really wait for delivery of irradiated red cells. You do need to make an order for red cells because there's clearly going to be an ongoing need for this patient. There is a risk, obviously, of transfusion-associated graft versus host disease, but this risk is small, and so the benefit of transfusion outweighs the risk. And again, using that concessionary release means that haematology are aware of the risk, and then the patient can be monitored appropriately after the event. And I think I saw somebody put something in the chat about informing the haematologist as well. Yeah, it's really important to keep haematology informed of these every time you go for concessionary release or outside of the norm, because then patients can be appropriate. Yes, somebody's put she can't get graft versus host if she dies from bleeding. Absolutely.
Right. Absolutely.
Spot on.
And I think and I think that's you don't want to delay the transfusion in the name of specific requirements not met. I think nobody should die from want of blood. So really apt statement.
Yeah, absolutely. I like that. So case number 5 is a severe anemia. A 65-year-old lady. She's been referred to the medical ward by her GP. So they took a full blood count sample at the GP surgery earlier in the day, and it showed a hemoglobin of 34, which is really low. So the MCV was low, and the ferritin in the blood film suggesting iron deficiency anemia. She has got historic transfusion results on the limbs, and a current group and save sample has just arrived in the lab for you. And the clinical team are on the phone asking for 4 units of red cells for urgent transfusion because that hemoglobin is so low. So what are you going to do with this case? Are we going to tell the clinical team they better take the emergency group O blood because this is a dangerously low hemoglobin? Or do we think we've got enough time to process our samples and release 4 units of red cells because this is a low hemoglobin? It does need some urgent blood. Are we going to tell the clinical team that we're not going to release any red cells because the patient is clearly iron deficient and should be treated with iron and not transfusion? Or are we going to discuss the case with the haematologist first because transfusion might be reasonable, supported by iron, and we think we've got time to go down that route? So we've got all sorts of options I can see coming up in the chat. So people saying 1 unit should be issued and then iron infusion. So we've got quite a spread here. So yeah, some people are saying take the emergency group O. Some people are going down, they're releasing 4 units from the lab. Majority have gone to discuss the case with the haematologist, which, yeah, I think is the right answer.
Yeah.
So why is this the right answer then, do we think? So the patient has been to her GP, so she's likely walked to the GP. This is probably a gradual decline in hemoglobin that the patient is coping with. There's no evidence that she's having a significant bleed. And so in this case, transfusion is not critically urgent. We have got time to think about this and step back a bit. And treatment with iron is indicated. It's an iron deficiency anemia. But discussing it with the haematologist is important because they might feel that because the hemoglobin is so low, a transfusion is necessary in this case, supported with iron as well. But just going down the iron route and withholding transfusion could have an adverse impact on the patient. So yeah, this is the time, the scenario to stand back and wait and have that discussion about transfusion and iron.
Thanks, Jenny. I think I just wanted to add a couple of points, and all of you may be aware of the Choosing Wisely initiative all around the world as well, that how do you actually then choose the right test as well as the right intervention. So from the Royal College of Pathology, there are a few key indications from transfusing wisely under the same heading, and avoiding unnecessary transfusions for patients with iron deficiency comes under, as one of the key recommendations. Now, in this case, there is a need to individualize, and therefore, I think as a clinician, as a hematologist myself, I would be actually, supporting that communication and understanding the need, because when somebody is having, even in an iron deficiency anemia, now, if the hemoglobin starts drifting down to less than 50, the important thing is how chronic it is and how slow the anemia has been actually developing, and, whether there is an ongoing blood loss, as well as whether the patient is having any cardiovascular problems. So these are all the different factors that a clinician is actually choosing. But also important is you're not treating the number, you're treating the patient. And you're not trying to normalize the number. But as Jenny said, that, it may be that the hematologist will say, we'll give 1 unit to take the hemoglobin level to safe levels, beyond that tipping point, and then you're actually correcting it. And another important point that we need to remember, from a clinical point of view, is even if we give the iron, we have to find out what caused that iron deficiency. Otherwise, we are really not managing the patient. Again, in 6 months' time, they're going to come back with a similar problem. So, we treat the cause of the iron deficiency, we give the iron, and only need the transfusions if they are actually having a bleeding, cardiovascular compromise, or if it is actually significantly low. Back to you, Jenny.
Lovely. Thank you, Shruthi. Right. Case number 6 then is a head injury. So 87-year-old male admitted to ED with a severe head injury. He's on warfarin and his INR is 3.4. So the clinical team want to give him some PCC, but they're unable to weigh him because he's too unstable. So your protocol, for the purposes of this, requires a patient weight to calculate the dosage and requires approval by the haematologist. So what are you going to do in this situation? This is probably a bit of a controversial case, but we can discuss that afterwards. So are you going to tell the clinical team that you're unable to release any PCC until they've weighed the patient? So are you going to tell them that you're unable to release any PCC until they've weighed the patient and had the request approved by a haematologist? Are you going to release 3,000 international units of PCC because in your experience that's what normally happens anyway, regardless of the patient weight? Or are you going to discuss releasing a lower dose of about 1,000 IU/PCC with the clinical team and contact the haematologist for further advice? So we'll have the haematologist would make this decision. Somebody's saying in the chat. Okay, so you'd phone the haematologist. Okay, so we'll see, yes, another spread that some people are waiting to have the patient weighed and the request approved by a haematologist. But quite a few are going to either release a lower fixed dose PCC or they talk to the haematologist about issuing a lower dose PCC. So why do we think number 4 is the right answer? And this was probably a difficult choice for those people who are working in labs that don't already offer fixed dose PCC. But fixed dose regime has been proven to effectively reverse the effects of warfarin and also allows rapid access to PCC in critical situations like this one, where the patient might have a life-threatening or sight-threatening bleed. And giving a lower dose and then following up with an INR 10 to 15 minutes later can guide you into whether further doses are needed. And in the SHOT report 2020, there was discussion around fixed dose PCC regime. So if you haven't read that, then you can go and have a read to learn more about that. And SHOT have also had reports in where delays in administration of PCC have resulted in patient death or serious issues with the patient. And also in terms of the haematologist approval, the CASLA did state that labs should have a pathway or hospitals should have a pathway for PCC release without haematologist approval in these specific scenarios where it's really important to give PCC quickly. So if your policy still requires haematologist approval and you don't have access to fixed dose in specific scenarios, then it's worth talking to your lab management about that to see what's happening in those areas.
Yeah, I think the main purpose is actually, ultimately is how do we ensure safety of the patients, and that is what you're trying to actually do. That if somebody is dying because of that bleed, you're able to actually stem that bleeding from that anticoagulation, give the minimum that is actually necessary, and review what more is needing to be done. I think we are okay. We have 2 more cases to go. It is 2:50. I think we are okay for time, so we can go through the other 2 cases as well, Jenny.
Okay, super, thank you. So the next one is with incompatible units. So we've had a 65-year-old lady come through ED following a traumatic amputation of the leg. No transfusion history on the limbs, and so they've sent you 2 group and saves per protocol. And you released 4 units of red cells ABOD compatible via your rapid release protocol 30 minutes ago. And your antibody screen results are now available and it's positive. So you think that some of the red cells you release may be incompatible for the patient, and you know that the clinical team have transfused one of those units, but you're not sure about the other 3. So what are you going to do in this scenario? Are you going to start an antibody identification, not worry about the red cells that have gone to the clinical area? They've gone, no worries. Are you going to start an antibody identification, phone up the clinical area and tell the team that they mustn't use the red cells that are down there and they must be returned to the laboratory immediately? Or are you going to start an antibody identification, inform the clinical team that the patient has a positive antibody screen and that the red cells that they have may be incompatible and they should only use them if clinically appropriate? So I can see loads of people choosing 3 coming through the chat. And yeah, most people have gone for number 3. A few people have gone for getting the other units back, but overwhelmingly number 3, which is correct. So that's great. So yeah, the transfusion is probably urgent. You don't know if the red cells are incompatible or not, but the need for transfusion outweighs the risk. Then you discuss that with the clinical team. And antibody identification does take quite a long time. So you can't really recall the units while you're waiting for the results. We didn't talk much about our emergency group O blood, but they might be as incompatible as the red cells that have gone out anyway. And it's still important, I think, to work through that recall process, even if the units aren't returned to you, they're given to the patient, because that just gives documented evidence that you've followed good practice and that everybody who's involved in patient care is aware of the risk. And again, using your concessionary release and letting the haematologist know is important as well, because that means the patient can be followed up and monitored appropriately after the transfusion. So last case, I think, mistaken identity. So this time we have a 52-year-old female who is undergoing planned surgery, but then suffers a significant hemorrhage. And there's no transfusion history on the limbs for the patient. So they send you 2 group and saves samples, which you get. The samples have been collected in accordance with your 2-sample policy, but the forename on both samples is spelt Sarah, whereas the request forms or the order is Sarah. And the clinical team are asking for 4 units of red cells urgently. So what are you going to do in this scenario? So are you going to reject both samples because they don't fit your acceptance criteria and tell the clinical team they should take the emergency group O red cells? Are you going to accept the samples under concessionary release, process them and provide red cells that are group O compatible with the sample, D compatible, sorry, with the samples? Or are you going to accept the samples under concessionary release, process them and provide red cells that are ABOD compatible with the samples? So, yes. See what people do. I think we're going to get quite a split on this one, looking at the chat. So this will be an interesting one. Yeah, so overwhelmingly people have gone for rejecting both samples. So 0 tolerance, yes. My preferred option, and in our hospitals we would accept the samples under concessionary release or deviation from SOP process, and then provide red cells that are group OD compatible with the samples. And I see some other people have gone down that route as well. So why this controversial one? So again, conserving your emergency group O red cells is important. And we all know that a 0 tolerance policy is really important for patient safety. And in a non-urgent situation, we would absolutely reject those samples. But rejecting the samples causes delay in provision of blood. We've only got 2, maybe O pos, O neg units out there. And 0 tolerance needs to be within reason as well. And if we go down the providing group O red cells dematched to the samples, then we're going down a safe route for this patient. And we can ask for more samples to be taken that are labelled correctly, that we can process in the correct way. We may take a decision to process the samples manually and not put them through the analyzers. That might then allow us to do electronic issue. Or we may decide only to process 1 sample through this deviation or concessionary release, and then get your properly labelled samples afterwards. And again, just using that concessionary release or deviation from SOP then allows that transparency and agreement from the clinical team that that's the appropriate thing to do in this case. So we've talked a lot about concessionary release, and I'm sure you have concessionary release in your labs, but I've put an example here in case people don't. And this is the one that we use in our hospitals, and it covers all the scenarios that we've looked at today, but also covers one that we didn't look at today, which is the release of D positive red cells for D negative patients of childbearing potential. And to make sure that the clinical teams are always given an indication of the risk, we include a script for the BMS, which is highlighted in black here. And this also means that the information that is given about risk isn't dependent on the level of the experience of the BMS. It's always the same. And on the right-hand side, the form also includes follow-up and audit. And this type of concessionary release helps to provide clear, concise and complete communication as well. And when I was a trainee BMS a long time ago, a wise haematology consultant said to me that for non-bleeding patients, the best place for the blood is in the fridge. But if the patient's bleeding, some blood is better than no blood. And that's always stayed with me working in labs. And obviously involving a haematologist at the earliest opportunity is really important, but we shouldn't be delaying providing safe blood components and products when the patient needs them. So hopefully what we've shown today is about not delaying provision of blood where the need for transfusion is clear, that you should question your local policies and procedures where they don't allow for concessionary release, deviation from SOP, or if you feel they're adding unnecessary complications or delays in blood provision. And we talk a lot about empowerment in terms of challenging inappropriate requests for blood components, which is really important. But empowerment is also about having the knowledge and the tools to provide safe components when transfusion is critical and it's not a normal scenario. And also for speaking up if your local practices don't support you to do that. So thank you. I'll hand back to Shruthi now.
Yeah, no, thank you, Jenny. I think, the overwhelming common theme that we've actually seen today is balancing that risk as well as the benefit and making timely decisions. And to make those timely decisions, you would need that clear, timely communication, which is ongoing between, within the lab, between the lab and the clinical teams and various teams. And at the other end, you also need to be aware that the patient may not even be in one site. It may be from an emergency, they go to the wards, from there possibly to the theaters. So it is that hyperdynamic situation which is constantly changing, and it is that clear communication that would be saving the day. So ultimately put everything in place and have those drills and have debriefs as well, so that every time that you have that activation, you're able to also understand what went well, what more can we actually learn to make the processes better, because ultimately what you're trying to do is ensure those timely transfusions happen and there are no patient harm events or deaths that are occurring due to the transfusion delays. And yeah, this just stems again the point that, when you talk about that teamwork, it is beginning and ending with communication. Now, there are several resources to address the delayed transfusion as well. So we had, we have the short bites. We also have short educational videos. So either through the app or on our website, or you can also actually then use these QR codes to actually get the relevant resources about delayed transfusions. And all the short reports are also available. So as I said, even if you search for Short UK in the App Store, you'd be able to actually download that. And, and although Jenny and I are sitting here presenting here today, it is again only through the reports that you people are submitting. So it is for the hemovigilance reporters that actually add richness to the, without that data, we wouldn't be able to make any of these observations. And it is the contribution from all the wide variety of the stakeholders that are actually there, as well as UK Forum for Funding. Now, two important things that I would want to also leave you with is we have a TACO webinar that is actually coming up in 2 weeks. And in the next day or so, we would be having the short conference website that is going to go live. And this is for our conference in July when the next annual report would be released. So that's, thank you.
Thank you very much. Thank you to both our speakers. Usually we'd use this last couple of minutes actually to share some closing remarks from the group, but I think that last point has caused quite some discussion in the chat. So I'm wondering if we might use those last 2 minutes just to pick up on some of the comments around the potential wrong blooding tube. Lots of comments suggesting, as Jenny said, it was a controversial decision. I'm wondering if Jenny or Shruthi, you want to come in and just respond to any of these comments for these last couple of minutes, because we have maybe 10 or so comments suggesting that they potentially wouldn't be comfortable taking that route and actually would have gone for O negative release. So I don't know if you want to come back in there and just we'll give you the last 2 minutes to finish up on that, if that's okay.
Yeah, sure. I did think that would be a bit of a controversial one. Certainly something that we use in our hospital, but I understand that some laboratories will have an absolute zero tolerance across the board. And so it is, working within, you have to work within your own procedures. We're not suggesting that lab staff go out just because we do it in our hospital, that everybody can do it in their hospitals. But it's about thinking about that sort of thing. Is rejecting the sample going to cause a delay that could actually result in the death of the patient? Is that what we should be doing? Or can we use a safer approach to getting some blood out to the patient whilst we get some properly labelled samples? Yes, you can go with your emergency group O blood. That's always an option, isn't it? And it is in this scenario as well. But when you have a sample, is it better to issue some blood from your stocks in your lab and leave your O negs and O positives out there just in case another patient comes along and needs those? So what I was trying to say today was to try and get people to think about that and maybe have those discussions with their lab managers and to see, are we right in just blanket rejecting samples if they're not quite labelled properly in these scenarios where the patient may bleed to death, not in another scenario where the patient is stable and we can wait and they can take some more samples.
Thanks, Jenny. Sorry, I had a coughing fit at that time.
I saw,
yeah. No, no, it is only, I mean, it's good that it is generated, and we are not at all telling you to actually break the rules, but it is actually talking about, what is actually safe and making those decisions. So it is looking at your policy, following it, and zero tolerance. Yes. Do you have that confidence? And if there is anything, so ultimately, yes, you don't want the wrong component going, but also look at whether your policies are also ensuring that there are no delays to the patients as well. So ultimately keeping that patient safety as well at the center of things. So, but thanks very much. And I think thanks for everybody for participating in the VVox as well. So that was actually really good. And it only made it, better with the interaction as well. So I'll shut up now and pass you back to Danny.
Thank you very much for joining us today. Thank you again to our speakers. Really good session, really good discussion. And we meet again on the 25th of May, the last Wednesday of May at 2 p.m. as usual. And all that information about registration, etc., will be released shortly. So thank you very much.